Good day. My name is Shruti Mony. I'm a current therapeutic GI fellow at the Johns Hopkins University in Baltimore, Maryland.
And I'm Jonathan Ragheb, an incoming GI fellow at the Cleveland Clinic, Florida. On behalf of myself, my esteemed co-authors, and especially our mentors, Drs. Amit Bhatt and Jason Klapman, we offer our sincerest appreciation to GIE for allowing us to share our research entitled The Impact of Margin Status on Outcomes After Endoscopic Resection of Well-Differentiated Duodenal Neuroendocrine Tumors. Now, Shruti, can you give the audience a little bit of an understanding why we felt the need to do this study?
So, Jonathan, as you know, duodenal neuroendocrine tumors have a low metastatic potential and follow an indolent course. Recurrence after resection of non-ampullary duodenal neuroendocrine tumors ranges between 14 to 17%. With its rising incidence and with the advent of neuroendoscopic techniques, be it EMR, ESD, or endoscopic full-thickness resection, there's been this constant debate on the optimal treatment strategy as well as surveillance duration for these duodenal neuroendocrine tumors. And I know for a fact that this is a topic that we're both very passionate about because it falls under that gray zone in endoscopy, wherein we don't have any consensus guidelines to aid in management. So we sought to investigate three things. First was looking at the recurrence patterns after endoscopic resection of non-ampullary duodenal neuroendocrine tumors. Second, to identify the risk factors, specifically the effects of positive histologic margins. And third, understanding the optimal surveillance strategies. So this is a retrospective multi-center study at 3 tertiary referral centers in the United States, including the Cleveland Clinic in Florida and Ohio, and the Moffitt Cancer Center in Florida, from June 2003 to December 2018. And we evaluated patients undergoing endoscopic resection of duodenal neuroendocrine tumors. In addition to patient demographics and pathologic features of the tumors, we looked at the endoscopic resection method as well as recurrence. And we classified tumors according to the WHO histologic classification and the European Neuroendocrine Tumor Society. R0 resection was defined as on-block resection with negative histologic and lateral margins. R1 resection was defined as removal of all macroscopic tumor, but positive vertical or lateral margins. And we considered margins to be positive if the neuroendocrine tumor was present less than a millimeter from the specimen edge. In regard to recurrence, we defined it as a post-resection biopsy being positive for a neuroendocrine tumor from either a visible lesion or close proximity to the resection scar or the resection scar itself. And finally, in regard to surveillance after endoscopic resection, this was done via upper endoscopy with or without biopsy at the resection site, and follow-up interval was at the discretion of the endoscopist. So as shown in the flowchart, we had a total of 340 patients with duodenal neuroendocrine tumors, of which 277 did not meet inclusion criteria. We included eventually a total of 63 patients with endoscopically resectable duodenal neuroendocrine tumors, and these included patients in which the tumor had a low mitotic rate, was less than 10 millimeters in size, confined to the submucosal layer, and without evidence of distant metastases. Among the 63 patients, majority of them, approximately 49 patients, underwent EMR, 7 patients underwent snare polypectomy, 4 patients underwent cold forceps polypectomy, and 3 underwent forceps polypectomy. And now switching gears to my co-author. Jonathan, tell us what we found in our study.
Great question, Shruti. Of our 63 patients, 20% would go on to develop recurrence or show evidence of residual disease. Importantly, none of the patients with recurrence had any signs of metastatic disease at the time of follow-up. Our mean and median time to recurrence was about 1 year, with the majority of patients developing recurrence or showing evidence of residual disease in that first year after resection. Interestingly, About a third of our patients were surveilled for more than 4 years, and in that group, none would go on to develop recurrence. We looked at characteristics specific to patients like age and gender, as well as tumor characteristics like tumor size, location, and grading to determine if there was any association between those factors and recurrence. We found that R1 or Rx margins were significantly associated with recurrence, whereas the other studied factors were not. We also looked at the type of resection and whether there was an association with recurrence, and found that among EMR, snare polypectomy, and forceps polypectomy with curative intent, there was no statistically significant difference in the amount of recurrence with any of these methods of resection. To eliminate any confounding by less accurate means of resection, like forceps polypectomy, we ran a subgroup analysis on EMR or snare polypectomy alone, and found that R1 or Rx margins remained associated with recurrence. Of those with recurrence, 77% would go on to have repeat management, whereas the remainder would have routine surveillance with endoscopic biopsy. Notably, none of the studied patient or tumor characteristics would go on to predict the need for repeat management.
And what did our study add to the existing knowledge in the matter?
Our study adds to existing knowledge by suggesting that, independent of resection technique, R1 or Rx margins are associated with recurrence in patients with well-differentiated duodenal neuroendocrine tumors less than 1 centimeter in size. Furthermore, most recurrences in our population occurred within 1 year of endoscopic resection, highlighting the importance of early post-resection surveillance in this population. And lastly, in our cohort, we did not observe any recurrences in patients who received more than 4 years of surveillance with negative endoscopic biopsies, suggesting that we may be able to reduce surveillance frequency after 4 years. Now, Shruti, what do you think should come next?
That's a vital question, Jonathan. Firstly, some guidelines suggest that endoscopic resection can be considered in duodenal neuroendocrine tumors between 1 to 2 centimeters in size. In our study, we did not look at that patient population, so I think we do need further studies to evaluate the risk of recurrence after endoscopic resection in this subset of patients. Secondly, as you rightly discussed, that after the 4-year cutoff, it may be safe to reduce surveillance frequency, given we did not find any patients with recurrence in our study. But I also think that we need further studies with a larger sample size to determine the sequelae of a delay in recurrent duodenal neuroendocrine tumor management.
Thank you for listening. We hope you found this study useful in informing your surveillance practices in the duodenal neuroendocrine tumor population.
Thank you.